Good evening. I will be presenting the DolPHIN trial study results on behalf of the DolPHIN study team. So part of the rationale for the DolPHIN study was, and the study population that we used, was that late initiation of ART in pregnancy is associated with increased risk of perinatal transmission and perinatal mortality in infants. So DolPHIN2 was a open-label randomized trial conducted in South Africa and Uganda, and we enrolled 268 pregnant women who were initiating ART in the third trimester. So we considered these high-risk women, and they were randomized into to either have efavirenz or dolutegravir-based therapy, and we followed them up until 72 weeks postpartum. We evaluated our safety and efficacy outcomes at delivery and at 72 weeks. In terms of our results, we had 74% of women who were in the dolutegravir arm. So there was superior response in the dolutegravir arm compared to the efavirenz arm. We had 74% of women, which was 89 women in the dolutegravir arm, who reached the primary endpoint of less than 50 copies per mil, and then 43% in the efavirenz arm. And then we also saw superiority with dolutegravir based on the Kaplan-Meier results analysis. So we had significantly shorter median time to suppression in the dolutegravir arm of 28 days compared to 82 days with efavirenz. And then at 72 weeks, we saw a similar proportion of women across the two arms who reached the secondary endpoint, which was less than 50 copies at 72 weeks. However, when we looked at the median time to suppression, we saw that there was a difference with dolutegravir having a shorter time period. Again, this was 4 weeks versus 12 weeks in the efavirenz arm. And then we also had low rate of discontinuation and switches, and then 6% of women in the dolutegravir arm and 10% in the efavirenz arm who had what we defined, protocol-defined virological failures. In terms of maternal safety, 18% of women had an SAE of grade 3 or above. There was no maternal deaths, and the majority of these events were related to pregnancy complications, investigations, and/or infections. And then for infant safety, we had 25% of infants who had an SAE of grade 3 or higher, and we had 11 deaths. 6 of these were around delivery, including 4 stillbirths. And then 4 mother-to-child transmission events. 3 of these we determined to be in utero transmissions, and these were in the dolutegravir arm. And then we had 1 postpartum transmission in the efavirenz arm, and this was despite optimal maternal suppression from delivery and serial negative tests in the infant. So what were the lessons learned? For recruitment, we found that we were able to recruit within 7 months instead of the 13 months that we anticipated. And part of this was due to the early engagement of stakeholders. This included pregnant women, advocacy groups, and healthcare providers. And this enabled us to build trust with them, and then also just to build awareness around participation in the trial. We saw that clear and transparent communication around the risks and benefit of trial and participation for these pregnant women was really essential, because it helped these pregnant women make informed decisions about participation at recruitment, but then also just continued participation during the course of the trial. We employed a multidisciplinary approach. So our qualitative component, which had key informant interviews and focus group discussions with pregnant, postpartum women and their partners, really helped us inform the planning of the study, but also throughout the course of the study, when issues came up, the qualitative interviews were able to help us understand that within the different contexts. And then our low rate of virological failures, we are down to or it highlights the need for ongoing adherence counseling and support throughout the follow-up period, particularly women who are identified as being high risk. And already the group of women enrolled into DolPHIN were high risk, given that they're initiating in the 3rd trimester. And then in terms of policy implications, our results support the WHO recommendations for the use of dolutegravir in pregnancy and breastfeeding. And with increased calls to include pregnant women in clinical trials, at a policy level, it'll be important to have the risk and benefit assessments for drug use in pregnancy separated by the exposure, by the trimester of exposure. This is given that you may have an increased risk early in pregnancy, but later on in pregnancy, there may be greater benefits for women who initiate late in pregnancy. Our perinatal our postpartum transmission demonstrated that even with undetected viral load during the breastfeeding period, this doesn't eliminate the risk of transmission. And with the increased use of dolutegravir and other treatment options, there will be a need for robust and enhanced pharmacovigilance systems to collect safety data routinely. Thank you.